So I used to believe that drug addicts were lesser people, and that they could overcome their drug problem if they were simply adequately motivated. I felt that way because that's what my parents and teachers taught me when I was a child, and society has reinforced that thought since then. That belief has led to individuals with addiction being the most stigmatized group in our culture. Some people would just write them off. As a practicing neonatologist in Central Ohio, I have treated many babies, and my goal has always been to have a healthy mom and baby who form a strong and loving bond, and then depend upon that maternal-infant bond to see that baby through the rest of its life of good development. The opioid epidemic continues to grow in Ohio. And with that, we see more and more babies who are being exposed in utero to maternal opiate use. When I first came to Columbus a dozen years ago, I would see maybe 4 babies a year who were opiate exposed. This past year, I've seen approximately 200. The state of Ohio reports that on any given day, there are over 80 babies hospitalized in an Ohio hospital due to drug withdrawal from maternal drug use. When you see a baby withdraw from its mother's drug use, one tends to recoil. The baby can cry inconsolably for hours and have difficulty in getting any sleep. In that picture, it is sometimes natural to think the mother must be a villain. How could she do this to her baby? How can she prioritize her drug use over the health of her newborn child? But now we know that mom is a victim of a chronic neurologic disease. And by changing our attitude, we can improve the outcomes for both these mothers and their babies. When I was in medical training, I was taught that drug addicts were highly manipulative drug seekers, and that we would look foolish to everyone if we tried to work cooperatively with them. So now we know that moms have a disease process. And consistent with that explanation, we know that there are specific genes that have been found that predispose susceptible individuals to a higher risk of addiction. A very typical scenario is someone has a painful procedure, either surgical or traumatic event. They get prescribed opiates by their physician. And then when that prescription expires, they discover that they start to go through withdrawal. In order to continue to be able to function as a parent, a spouse, an employee, they need to find another source of opiates. And then eventually, that leads to illicit drug use. The other high-risk group are those with mental health issues that are inadequately treated, especially when accompanied by high-risk social situations. Blaming these individuals for their drug addiction is like blaming the individual who has epilepsy or dwarfism. Currently, when a mother is pregnant and opiate dependent, we have to counsel her against opiate abstinence, as it would be risky for the fetus to withdraw inside of mom. The best treatment we currently have is to replace her illicit opiates like heroin with prescribed pharmaceutical-grade opiate replacement therapy, and most commonly used is methadone or buprenorphine, otherwise known as Suboxone. These medications allow mom to avoid risky drug-seeking behaviors and allow her to participate in prenatal care and have improved nutrition, and has been shown to result in improved newborn outcome. But these medications do cross the placenta, and they do place the baby at increased risk of withdrawal when born. Currently, when babies are born who are drug exposed, the hospital uses a scoring system to try to quantify how severe the baby's drug withdrawal is. They look at things like excessive crying, excessive sucking, maybe jerking activity, or spitting after feeds. But of course, these are all activities that you can find in a lot of babies for a lot of reasons. This scoring system inadvertently creates an adversarial relationship between the new mom and the healthcare team. If the baby scores too high, then the baby goes to a neonatal intensive care unit to receive medication to help control the severity of the baby's symptoms. A typical NICU stay for withdrawal would last for 2 weeks or more. And imagine how long that 2 weeks must seem to the mom, who may have other children to care for at home or transportation challenges that would prevent her from visiting as much as she would like. And imagine how frustrating it is that this is the outcome after she did all the difficult things we asked her to do. She gave up her addictive substance. She took a daily medication that may have resulted in some side effects. She had frequent doctor visits, and she had to answer a lot of questions from probing professionals. In the end, about 80% of these moms are going to take their babies home, but too often this process has interfered with her confidence in her ability to care for the baby. And that adversarial relationship, it has made it difficult for her to be able to listen to teachings that would help her be a better parent at home. So in 2012, I heard Dr. Ron Abraham speak about a program he had for addicted moms and children at the First Center in Vancouver, Canada. Now, this was in the Canadian province finance system. And so he was able to keep his moms hospitalized for approximately 2 weeks before and then 2 weeks after the delivery. And that allowed for a lot of stabilization and teaching. But I think more important than that was that he practiced a philosophy called harm reduction. And harm reduction means that we all decide at various times to participate in some risky behaviors, but we can learn how to minimize the harmful effects of those behaviors. So in this case, with harm reduction, mom may not be able to entirely give up taking drugs, but she can drastically decrease the amount of drugs, she can get good prenatal care, she can have good nutrition, and she can have a much better outcome for her babies. And importantly, if she should have a relapse, we are not going to throw her out of the program because this is a chronic disease and we expect that. So it seemed like we could do a lot better here, and a group of us got together and we talked about how we could improve the care for addicted mothers and children here in Columbus, and do so in a way that was consistent with our own healthcare finance system. In 2014, we received a State of Ohio Moms Grant, and that allowed us to open the MERCK Clinic, stands for Mother Infant Recovery Clinic. The MERCK Clinic was open 1/2 day a week, and mom was able to come get prenatal care, medication-assisted therapy with Suboxone, and group counseling all in one visit. And then for the rest of the week, we had peer mentors in the community to help mom. We practiced a harm reduction philosophy, so moms were not removed if they were unable to drop a clean urine each week. We also trained hospital nurses in how to approach addicted moms in a non-judgmental fashion. And we trained nurses in how to be able to teach moms to be able to console their own infants without the need for medication and separation, utilizing techniques like skin-to-skin care, breastfeeding, and environmental modification of the postpartum room. So mom would room in with the baby. We tried to bring the baby's care to mom's room rather than the baby to the brightly lit and loud well baby nursery. And we tried to provide the care on the baby schedule rather than on the hospital schedule. And the other thing we did was we removed that barrier-creating system that quantified the severity of the withdrawal. And we simplified it to just two things. Could the healthcare team and mom agree that they were able to console the baby adequately in the room? And the truth is, these moms performed heroically, and they agreed with us 100% as to whether they could console their babies. And the second thing is whether the babies had excessive weight loss that would signify a physiologic intolerance to their withdrawal. The results, I think, were startling. Typically, babies whose moms are in drug treatment programs, over half of those babies are going to need to go to NICU for medication with the resultant separation. In this group of 38 babies in this pilot project, only 4 required NICU care. And that is a marked improvement over anything that we've been able to do. In our institution, we were right around 50% on the number of babies who needed to go to NICU. 90% were able to go home with their moms directly from the postpartum floor. They went home on no medications, and on follow-up, none of those babies required inpatient or outpatient care for withdrawal after discharge. The advantages of this program are quite significant. Moms develop the confidence in their ability to care for their babies, and they learn techniques through practice of how to console their babies for when the baby would become irritable after discharge. I think we strongly encourage this maternal-infant bond, and that should lessen our concerns about the risk of child abuse and neglect in the future. There were huge financial savings by avoiding expensive, prolonged NICU stays. And lastly, moms who were able to successfully transition to motherhood now had the self-confidence to feel like they could overcome their addiction disease. We know that the best predictor of long-term child development is to be present in a loving, stable family. This program, which was strongly family-centered, has the potential to change shattered realities into potential good outcomes. However, in order for us to be able to distribute this program to other centers, and I think this is a strong candidate for a generalized use program because it requires no expensive equipment and it is easily scalable to other delivery facilities, we need new sources of funding. I think it's time for us to properly prioritize for these at-risk infants. Thank you.